prolonged. And that's what reason you get demyelination. Like for instance, a normal, as you know, we have 45 to 50 in upper and lower extremities, but person who is demyelinating neuropathy, CMT, we have like 20, 15 or so. So that's again, so back again, what do you do with peripheral neuropathy? All the peripheral neuropathy workup based on a clinical, consider familial versus acquired. I talked to you, and consider common treatable causes. The most common, as I mentioned to you, is metabolic, and more so is diabetes. Toxic. You have many causes. I already talked about the drugs. I already provided to you the information about other like toxins in the sense that, like large, like basically amyloid and other toxic conditions. And basically people, those who are taking, drugs, and again, cocaine can cause neuropathy, nutritional, vitamin B12, vitamin B1, vitamin B6. The next one, this here, immune mediated, and I'm going to talk about infectious, which is basically, like various infectious, including, by the way, the COVID. COVID can cause infectious neuropathy, and we're writing a paper on that. Paraneoplastic and the vasculitis. I'm going to talk about immune mediated. That's my topic today. So here, I want you guys to understand the acquired immune polyneuropathy, where we have acute and you have chronic. The acute, it might like demyelinating, it's Guillain-Barré syndrome. And here, I'll talk more about it. The MMN is another form, which is called Chinese form of Guillain-Barré. Guillain-Barré, and seen more again it started in China, and this one has decreased amplitude. Miller-Fisher syndrome is another AIDP, which causes three things: ataxia, areflexia, decreased reflexes, and then you have oculopharyngea, you have problem with the eye problem there. So eye problems, extraocular muscle problem, and ataxia. And then you have like no reflexes. And the other one here is MSAN, which MSAN has to do with the sensory findings in addition to Guillain-Barré type. So chronic, you have CIDP, classical, we'll talk more about. This is two types. And then MedSam, again, is like sensory findings. MMN is kind of where we have conduction block. And the last one is very rare, is called DADS. So back again, Guillain-Barré, Guillain and Barré, they were third-year medical students in 1916 in France, and they described an immunocytological association to Guillain-Barré type. So chronic, you have CIDP, classical, we'll talk more about. This is two types, and then MedSam, again, is like sensory findings. MMN is kind of where we have conduction block, and the last one is very rare, is called DADS. So back again, Guillain-Barré, Guillain and Barré, they were third-year medical students in 1916 in France, and they described an immunocytological association to Guillain-Barré type. So chronic, you have CIDP, classical, we'll talk more about. This is two types, and then MedSam, again, is like sensory findings. MMN is, okay. And the last one is very rare, is called DADS. I don't know why I'm. So back again, Guillain-Barré, Guillain and Barré, they were third-year medical students in 1916 in France, and they described an immunocytological association to Guillain. Megan, I don't understand it. Why I'm having repeat this whole thing? Okay. The incidence of Guillain-Barré is 1 to 2 per 100,000 per year. Okay, and the last one is very rare, is called DADS. I don't know why. So back again, Guillain-Barré, Guillain and Barré, they were third-year medical students in 1916 in France, and they described an immunocytological. Okay. Coming back to the incidence of Guillain-Barré, acute Guillain-Barré is 1 to 2 per 100,000, male and female. Male are slightly more than the female. And then basically the clinical features of classic acute Guillain-Barré, you have proximal and distal weakness, and you can have a severe quadriplegic. Later on, some cases, they can become bad. You can have a cranial nerve involvement in some acute cases, and ophthalmoplegia. So back again, sensory, usually you have pain. Why I'm having repeat this whole thing? Okay, you have pathophysiology. So back again, sensory, usually you have pain. Why I'm having, okay. Okay, so back again is the sensory features over here described. One thing which I want you guys to understand this here, Negam and others, is acute Guillain-Barré, you must not admit that patient in general regular ward because you have a lot of autonomic dysfunction, which is a blood pressure problem, trachyarrhythmia, bradyarrhythmia, heart block, etc., etc. So always having monitor setting. Sometimes your patients, you have prodromes, some flu-like symptoms, URI, and then you have sometimes CMV, EBV, Coxsackie, etc. And there are a lot of other bacterial illnesses which you can have, like Campylobacterium jejuni, particularly the Amman form, and Mycoplasma pneumoniae in patients in the children. Vaccination, question mark. It was described in 1976, but hasn't been proven. Rabies is another one. Pathophysiology of Guillain-Barré, which I'll describe how the demyelination takes place. So if you look at here, whatever the bacteria or virus is on here, and this one is basically have interleukin antibodies, and then it causes, like myelin sheath disruptions, C59, and causes myelin sheath problem. Okay, that's the reason you have demyelinating. Okay. But in patients with a nerve problem, you have problem, not the myelin sheath, but you do have nerve problem over here, which causes decreased amplitude. Okay, so what do you do? So once you have decided that patient looks like a decreased reflexes, has progressive weakness, and then the next thing which you do the CSF studies, spinal fluid. And here it is, the spinal fluid, you have what's called proteinocytological dissociation. Not only albumin, okay, you can have IgG increase, oligoclonic bands can be higher, and so that's important. And sometimes when you do the CSF, the first or second day, you may not find an increase, so sometimes you have to repeat it. The next test which I'm going to talk to you all is basically nerve conduction and EMG later on. And more common is you have demyelination like AIDP, classical Guillain-Barré, or a demyelination, but it takes 1 to 5 days, sometimes 7 days to cause this, the problem with the demyelination. And as I mentioned to you, the Amman form, we have decreased amplitude. And two important things that you always do, F wave, and the other one is H reflex or H wave. We normally don't do H wave, I do F wave, okay, which is important. So back again, differential diagnosis of AIDP, you have critical illness, polyneuropathy, vasculitis, Lyme disease, tick paralysis, porphyria, sarcoidosis, and sometimes you have the diphtheria, botulinum, and you have periodic paralysis, okay? Sometimes, like either potassium, hyper or hypo, rare. But again, that's a differential diagnosis. So here is the important thing for you guys to understand. Now, I already mentioned to you distal latency, particularly in demyelinating form, is markedly prolonged, okay? And then you have F wave is very, very much prolonged. Just upper extremity, F wave. What if you guys understand what F wave is? F wave is antidromically. You stimulate the nerve, like now you have black and red, you convert, just reverse it, so red to black. So it goes intradromically. and depolarizes the neuron at a critical time, and it fires back. So it's called F wave. And F wave, because there's a root involvement, and therefore you have in AIDP, so you have prolonged F wave. And sometimes you don't get F wave. And the third thing which you get is conduction block, and I'll show you the picture. So back again, Guillain-Barré are these types, okay? You have classic sensory motor, you can have a pure motor, you can have just paraplegic form, and then there's another entity is called pharyngeo-cervical brachial form. You have a 7th nerve, 10th nerve, they have difficulty in speech, and brachiocephalic form. And then you have bilateral facial form, and then you have this Miller-Fisher, ataxia, sensory, pure ganglionopathy, and we have a lot of cases. And the Miller-Fisher syndrome, which is again ophthalmoplegia, ataxia, and the absent reflexes. And with Bickerstaff is more like seen in pediatrics, and it's got encephalitis. It's a rare, very uncommon. So, are you guys hearing me so far, everybody? Okay. So anyway, what do you do for the treatment for AIDP? Supportive care. Make sure that you get the respiratory failure controlled. So you always do the vital capacity, and you have, hypoxemia, difficulty in secretions, etc. Take care of that. And if needed, breathing, you may have to have intubate the person. The next thing, AIDP, the treatment is IVIG. Okay, no steroid in acute cases. Okay, and basic thing is that you can also use plasmapheresis if somebody cannot tolerate IVIG or some problem, but IVIG is the first one to go. So back again, the second type, which is called MMN, is non-demyelinated. It's called, it's also called Chinese paralytic syndrome, described in Wuhan area, like the 1970s. Okay, and this one is acute axonal form. And in most cases, they have like 60–70% of cases, they have Campylobacterium jejuni. If you do the, like blood test, you have abnormalities there. And you have this immune attack, whatever the things I described to you earlier, it affects the plasma lemma and node of Ren, like the 1970s. Okay, and this one is acute axonal form. And in most cases, they have like 60–70% of cases, they have Campylobacterium jejuni. If you do the, like blood test, you have abnormalities there. And you have this immune attack. So back again here, things I described to you earlier, it affects the plasma lemma repeating it, like the 1970s. So anyway, and this one is acute axonal form. And in most cases, they have like 60–70% of cases, they have Campylobacterium jejuni. If you do the, like blood test, you have abnormalities there. And you have this immune attack. So back again here, things I described to you earlier, it affects the plasma lemma repeating it, like the 1970s. So, anyway, and this. All right, my friend. So F wave may be normal or prolonged, but you have decreased amplitude that I showed you earlier. MSAN is not very common. It can be associated, it's like MMN, except you have more sensory symptoms. And here you have GM1 antibodies can be associated with this, okay? And immune attack is against plasma lemma and node of Ranvier. So Miller-Fisher already described to you. It's not, we don't have a lot here in the US, but in Japan and other parts of the Asian countries, you do have Miller-Fisher pretty high. You have three things I mentioned to you. And the antibody here is again GQ1B, okay, which is important for Miller-Fisher syndrome, and is present. And here are the things which I'm going to tell you guys. GBS with SARS-CoV. 5 patients, this is very recent, 5 patients in Italy presented with the Guillain-Barré who tested positive for COVID-19. 3 patients with MMN type and 2 patients with demyelinating type, like classical Guillain-Barré. And they had a good response to IVIG. Okay, so back again, the next entity, which is a chronic IDP, chronic inflammatory polyradicular neuropathy. And there are two types. One is progressive type of CIDP. It will be in the next slide. And the other one is relapsing type. For instance, somebody who has classical Guillain-Barré, got IVIG, gone home, doing well after 4 months, comes back again with the similar symptoms. So that's a relapsing form. And again, male and females, like the prevalence is 1 to 2 per 100,000. And the distribution is similar as AIDP I described to you. So back again, sometimes you can have autonomic symptoms. And again, I was telling you that CIDP is two types earlier, is a chronic progressive form and the relapsing form, okay? And prognosis is worse with the progressive form, but relapsing form, they do well. Get IVIG, they respond well. So here are the different criteria for this, but I'm not going to go into more detail. They both have motor and sensory findings, same, and they have increased CSF protein and abnormal nerve conduction studies. And you might get both AIDP and CIDP. EMG can be abnormal, but it doesn't come right away. It takes 10 days or 15 days when you can get acute denervation, fibrillation, and positive shock wave. So back again, here are the things. Distal latency is prolonged in a chronic form, in demyelinating form. In Amman form, you have decreased amplitude, and you have a conduction block. Okay, and I'll show you what conduction block. So prognosis for CIDP is reasonably good. 70% are said to make good recovery. Now, I want you to just understand this here. I told you in my AIDP slides that you do not use steroid, no corticosteroid. That's a different in CIDP. We do start steroid and other immunosuppressive compounds, okay? So back again, other entity which I want to bring to your attention is called multifocal motor neuropathy with conduction block. It's an immune-mediated disorders, but it has nothing to do like AIDP or CIDP. And you have this particular entity, you have weakness of biceps, and you may have fasciculation. After a couple of months, you have weakness of quadriceps on the other side. So it's gone up scattered, and you have muscle atrophy and fasciculation and cramps. And here, what you do when you do the nerve conduction studies, clinical, you have no upper motor, no hyperreflexia. You can have fasciculation focal, but no, you don't have any upper neuron finding. So that's what you need to remember between ALS and multifocal neuropathy with conduction block. Sensory normal, reflexes are preserved. And then you have progressive form, like you have one side, 1 week muscle weakness, couple of months later, the other muscle got weakened. And so here are the nerve conduction for this. You have the studies all over, and you find, nerve EMG, extensor, here are the muscles which we use, extensor hallucis longus, tibialis anterior, and gluteal muscle if needed, but not all the time. All the time, biceps brachii, you do the EMG, sural nerve, you do the sural snap, median snap, and ulnar snap, and radial snap. And FOA median, ulnar, and soleus, we have H reflex. Again, these studies are important for you to understand. So here I was telling you, so this one here, the distal latency is pretty good, and but amplitude is good. But if you look at here, there is a dispersion here, this called dispersion. And there is a decreased amplitude here too. So that's basically, suggestive of conduction block. You can see this type of things too in patients with MMN, this type of features. And so back again, so the EMG abnormalities I had mentioned to you, fibrillation and positive shock wave in GBS and acute CIDP. And these are due to the nerve ending damage. But these things, you may not see fibrillation within 7 to 14 days. Chronic denervation, you do polyphagic potentials, increased amplitude, and sometimes complex repetitive discharge. It's like myotonia type. I call it motorcycle sound. That's complex here. Reflect. So back again, here is a fibrillation, and here is a positive shock wave in acute cases. And sometimes it can be in chronic CIDP too. And back again, CRD, and this is the polyphasic potential, which you see in chronic cases. CIDP, you do see this, or any kind of chronic neuropathy. So what do you do? The lab studies, basically CSF protein can be, in CIDP, normal or can be mildly increased. They have also GM1 ganglioside antibodies can be positive. And it can be seen in many other conditions in MMN, but it can be seen in others. Okay, anti-GM in patients with with MMN is 80%. So pathology, which I'm showing you, this is a normal malnated exon, but you look at here, this is abnormal multifocal involvement, okay, and large fibers. So what do you do? Now, MMN, the treatment is IVIG. Okay, you can give other entities, but usually you can give. In patients with CIDP, you can use steroid, but you can also use other immunosuppressive therapy. After acute cases, you use IVIG. So back, one more time, so all the CIDPs, every type, and MMN, no steroid, and next slide will show you. But in acute, cases of CIDP, we use IVIG. You can also start steroid, and you can do other immunosuppressive therapy. Contrary to acute cases, AIDP, you do not use steroid or immunosuppressive therapy acutely. Okay, you can use steroid, but not very good. I use mycophenolate, which is another one, or you can give, like Imuran if needed. And by other cyclophosphamide, others have been used in patients with MMN. I don't use it. Okay, so coming back to this is your summary slides for chronic demyelinating neuropathy. I already mentioned to you that you have basically CIDP, two types, whether either relapsing form or progressive form. All of them, the weakness is proximal and distal, and you have sensory loss maybe. And then you have monoclonal protein occasionally, and then you have GM1 rarely. But MMN, GM1 is very positive. See here in MMN, and I'll talk about it. Abnormal CMAP, usually symmetric. And then, like prednisone, it can use, and plasma exchange, IVIG, you can use other immunosuppressive therapy. That is very rare. It's called distal axonal, like demyelinating neuropathy, rare. Clinically, these people, they have decreased sensation in a symmetrical fashion. These are like diabetes type. But then you have abnormal nerve conduction studies. And then you do that, blood IgM kappa can be increased in some cases, some of them no IgM. Patients who have IgM kappa, they respond well, okay? Abnormal, like CMAP is usually symmetric, and SNAP is also symmetric. Conduction block is rare, and the response is not very good. Okay, you can try, but not very good. The MMN is good, and there are symmetrical, multifocal, and they do have GM1 antibodies very often positive. And conduction block is very frequent, okay? And they do respond to, they don't respond to anything else except IVIG. People have we don't use cyclophosphamide, but again, some people have used it. MedSum is very rare. Remember, MedSum is chronic, just like these patients have sensory findings, and they're symmetrical, multifocal, and these patients, the weakness distal more than proximal, and conduction block is very frequent, and they do respond to prednisone and IVIG. So with this, I am done with most of the things. Some of the things I want you guys to understand. These are the rare conditions, rare CIDP. It's called neuropathy. I have antibodies in younger patients with sensory ataxia, very rare. Or antibodies, other connecting is another one, very rare. IgG4 antibodies, which is another rare. And these entities, the only way you can do it when you send this test, and you can send this test to outside. And we don't use it routinely unless until patient is young, not responding well, and having. So then we think about, like neurofaxing or connecting antibodies, rare. But I want you guys to know that. And they don't respond to steroid, this group, they respond to rituximab. Okay. So what I've done here, this is my summary slides. Peripheral neuropathy accounts for approximately 10% of all neurological disorders. Peripheral neuropathy can be inherited and acquired. There are various forms, which we have described earlier, toxins, etc. Workup is a clinical exam and common treatable causes first. Important diagnostic, electrodiagnostic tests, EMG nerve conduction, and sometimes radiology, X-ray to suggest that there's no hypertrophic changes in CIDP in the lumbosacral or cervical radiculum, cervical areas. And you have acquired immune polyneuropathies, are major subset of peripheral neuropathy, which I described to you. Summarizing again, you have acute, you have a chronic. And acute and chronic is two forms. Acute, you have many forms. Acute, you have the you have Amman type, you have Miller-Fresser syndrome, and then you have, pure. Then you have a chronic. You do have, many types, relapsing and progressive form. And again, you can have Amman type or demyelinating type. And so these are all different forms. The important thing in the treatment in CIDP and AIDP acute form, AIDP, you do not use steroid. Okay. For the chronic, you can use steroid. You do have, many types, relapsing and progressive form. And again, you can have Amman type or demyelinating type. And so these are all different forms. The important thing in the treatment in CIDP and AIDP acute form, AIDP, you do not use steroid. Okay. For the chronic, you can use steroid. You do have. I don't know why I'm repeating, my friend. Relapsing and progressive form. Okay. And again, you can have Amman type or demyelinating type. And so these are all different forms. The important thing in the treatment in CIDP and AIDP acute form, AIDP, you do not use steroid. Okay. For the chronic, you can use steroid. You do have. I don't know why I'm repeating, my friend. Okay, my friend, I'm done. Any question, Nijam? Nigam? Hello? Okay, my friend. Unmute, my friend. Nigam.
You hear me, Professor Mishra?
I'm done, but I'm asking, anything else? Can you hear me?
I don't know what is going on this Zoom. Professor Mishra, you hear me?
Yeah, I can hear you, but can you hear me?
Okay, I don't know what is.
Okay, can you hear? I can hear you, Nigam.
Mishra?
Yes.
All attendee, any problem for hear me?
I'm not having any problem. Do you guys have any problem? Hello, hello.